So pulmonary embolism is just a disease or a condition where there's an obstruction to blood flow somewhere in the pulmonary arterial system by some kind of embolus or emboli or a blood clot. So what happens with this is when that blood flow is blocked, that lung or that area of the lung is not able to participate in gas exchange. So the air comes into the alveoli, but you don't have circulation in the surrounding capillaries, so oxygen's not getting into the blood. And this is what we know as an imbalance in ventilation and perfusion. So this is another version of a ventilation-perfusion mismatch or VQ mismatch. So because this lung portion is not available for gas exchange, we can develop hypoxia. Now the degree of this distress, it really it depends on the degree to which the lung perfusion is affected. So if it's a tiny little embolus affecting circulation to a fairly small number of alveoli, it may only cause some mild shortness of breath. This right here is a PE that was surgically removed from a patient, which is just pretty astonishing. That's massive. Yeah, I don't know anything else about the patient, but that's just really cool looking there, just to give you a visual. But with this, it's not uncommon for these patients to have signs and symptoms, kind of vague, but signs and symptoms for up to even a week before being diagnosed with this PE. But when you have larger pulmonary emboli, it can obstruct a bunch of different smaller branches of the pulmonary circulation, and then they may have a sudden onset of severe dyspnea. And in really severe cases, this can be accompanied by your hypotension, your severe respiratory distress, and obvious hypoxia. And occasionally they'll also complain of real shortness or a real sudden onset of sharp chest pain. With these patients with your significant PEs, they can deteriorate very, very quickly. And it doesn't matter how well you oxygenate or ventilate them or try to increase the blood pressure through fluid administration, it's not going to work because you can't get oxygenation into the blood. So definitive treatment is going to be anticoagulation to prevent any further emboli formation. It's going to be fibrinolytic therapy to break down any existing clots, or less frequently, embolectomy, where they actually go in surgically and remove that clot that way. So our common risk factors usually are patients who are going to have existing medical conditions that kind of make them more likely to have some kind of abnormal clot formation. All right, so one of the most common ones is going to be a DVT, or deep vein thrombosis. This is where you have a thrombosis, and the only difference between an embolus and thrombosis is in where it starts. Like, it's formed here and it stays there. Embolus, it's formed and it moves throughout the body somewhere. Okay, the DVTs are more common to the pelvis or lower extremities. Blood clots are probably the most common cause of pulmonary embolisms, but air, fat, bone marrow, even amniotic fluid in circulation can also cause your PEs. And some of your bigger risk factors are going to be your recent surgery of any type, cancers, immobilization, usually from like injury, illness, obesity, fractures, prolonged travel, things like that, and estrogen use, both hormone replacement and contraceptives. And then, of course, older age. So we want to suspect a pulmonary embolism in any patient who has otherwise unexplained dyspnea and hypoxia, which is an SpO2 of less than 95%. Early on, the breath sounds are going to be clear and equal, although the non-perfused portion of the lung will start to have some atelectasis, usually at 1 to 3 days after the onset. So depending on how severe and how long this has been progressing, you may have some diminished breath sounds in a localized area. Look at their history. Get a really good history for them, because it may reveal some risk factors and kind of increase your suspicion there for a pulmonary embolism. There are some other signs and symptoms, but we can't necessarily rule them out if they're not there. So like chest pain, back pain, shoulder pain, upper abdominal pain, that chest pain may be pleuritic. They may experience some syncope, they may have hypotension, tachycardia, they may have hemoptysis, they may have swelling of a leg. This is, that one's indicative of your DVT usually. Severely hypoxic patients are going to present with your cyanosis or even mottling. They may be cool and diaphoretic with ultramental status, and they may show varying degrees of respiratory distress, failure, or arrest. So treatment. Pre-hospital treatment, we can't fix the problem. So our goal is to treat them with oxygen titrated to their SpO2. If ventilations are adequate, or BVM device with supplemental oxygen if ventilations are inadequate. Okay, start an IV. If they're hypotensive, give fluids according to your local protocols. If they are hypotensive and they have a pulmonary embolism, they're likely to be very, very hypoxic and usually acidotic as well. So you need to be prepared for respiratory and cardiac arrest. And as with any critical patient, make sure that you notify the receiving facility early on.